the CAH, the main disorder lies within the steroid pathway. Here we have seen that in the CAH, the most common deficiency is 21 hydroxylase deficiency. So if there will be 21 hydroxylase deficiency, there will be a less amount of aldosterone and less amount of cortisol. If there is less amount of aldosterone, you can see leads to salt and water wasting, and cortisol will also be less. So ultimately the ACTH will increase because of no negative feedback. Okay, and also due to accumulation of progesterone and the 17 hydroxyprogesterone and androstenedione, some manifestations will be there. So with the help of 17 hydroxyprogesterone, like it is can be used as a screening test for CAH. Okay, and androstenedione, mostly if it is increasing, like then it can lead to features of virilization. It can be a heterogeneous precocious puberty or can be ambiguous genitalia in females. This is mostly in males. So after CAH will continue the other things. So CAH is the most common cause is 21 alpha hydroxylase deficiency, 90% of the cases. And this leads to reduced cortisol and aldosterone as seen in that flow chart and increase androgen synthesis. So what will be the symptoms? Include hypoglycemia, salt loss, hyperkalemia, ambiguous genitalia in XX and precocious puberty in XY individuals. Gestational hyperandrogenism. By the name it suggests more androgen during pregnancy. So it will lead to virilization in the mother also. So mother will develop the hirsutism and virilization of XX fetus. That means ambiguous genitalia will be there. It is generally caused by like leuteomas, which is a rare gestational tumors. It is a type of like non-cancerous tumors, or maybe there is a maternal use of some androgenic drugs. So leuteomas are the tumors which are non-cancerous, rare type of tumors generally developed during pregnancy in the ovaries, and it spontaneously regress also. It secretes testosterone and DHT. Then placental aromatase deficiency. Deficiency in the placental aromatase leads to the decreased conversion of the testosterone to estradiol, because for conversion of testosterone to estrogen there is an enzyme required which is placental aromatase. So it is important in the female part. So placental aromatase, if it is deficient, it is a rare type of thing, and mutation is generally at CYP19A1 gene, which can be assessed by amniocentesis during genetic testing by maternal serum. In this deficiency, you can see increased androgens and decrease estrogens. So because of increased androgens, virilization will be there, and decrease estrogen. So virilization and ambiguous genitalia can be seen. Again, this XY DSD specific disorders, we will generally see here the three type of disorders. One is severe syndromes, 5 alpha reductase deficiency, complete androgen insensitivity syndrome. So starting with this CAIS, which is a complete androgen insensitivity syndrome. So in complete androgen insensitivity syndrome, there is defect in the androgen receptor. Generally there is a mutation in the androgen receptor. So mutation in androgen receptors of XY individuals leading to no response to androgens. So no internal genitalia present due to MIH from the Sertoli cells which inhibit the Mullerian ducts. So because testosterone, the receptors are like insensitive to testosterone, so Wolffian duct will not be developed. Wolffian duct will not developed, and that seed, that is seminal vesicle, epididymis, vas deferensis, these all will not be like formed. This ejaculatory duct will not be formed. So there will be a presence with a female external genitalia and the abdominal testis, but like no uterus or menstruation. Breast development will occur at puberty due to the conversion of testosterone to estrogen, because placental aromatase that enzyme is important for this conversion, and that is there. So the conversion will be there but there is like insensitivity at the pituitary and hypothalamus level, but there is no pubic and armpit hair. Okay, so both testosterone and DHT cannot act. Therefore, there is no internal and external genital development. So overall, there is androgen insensitivity in these females. So next is 5-alpha reductase deficiency. Because of this deficiency, the external genital organ will not form. So autosomal recessive disorder leading to the inability to convert testosterone to DHT, because of which the male internal genitalia develop. But external genitalias are predominantly female, often connect to a blind ending vagina. So often identified at puberty, when the masculinization occurs, then we get to know that this is a male. Effects of 46XY individuals: bilateral undescended testes, male testosterone levels, absent uterus, there will be high testosterone and muscle growth, all will be normal, but you can see here external genitalia like a female. So since the childhood you will recognize her as a female, but during the time of puberty, after puberty, it will be identified as male. So next is Sewer syndrome. Sewer syndrome is a gonadal dysgenesis in XY individuals leading to a female external genitalia, but with a fibrous tree gonads, probably like mostly no ovaries will be there. These patients will be have normal stature, and gonads will be testis, dysgenetic. 85% causes are known, but 15% mutation in the there is mutation in the SRY gene. So here there is a dysgenetic testis. Because of dysgenetic testis, and like dysgenetic testis, this anti-Mullerian hormone will be absent. Mullerian duct will develop. Testosterone is absent. Therefore, external genitalia will look like females. Wolffian duct will regress. No male internal genital organ. Seed will be absent. Here, the main hormone is the androgen, which is decreased in a decrease like ratio. So, breast development will be absent, LH-FSH will be high, and primary amenorrhea will be there. Ovotesticular DSD. Ovotesticular DSD is like presence of both ovarian and the testicular tissues in the same individual. Because same are present, can present as separate ovaries or testes or ovotestis, both tissues type in a one structure. 80% of these individuals are in females, like XX individual. These are mostly infertile. At puberty, breast development and menstruation may occur. Features will be ambiguous genitalia, abnormal vagina, and hypoplastic uterus, undescended testes. And you can diagnose these patients with the help of the gonadal biopsy. So if you will classify in a table these patients like Sewer's 5-alpha reductase and CAI syndrome, then you will see there is gonads are tested in 5-alpha reductase and CAIS, and these are externally female. Actually all are externally female, okay, but testis is present in 5-alpha reductase and CAIS. In Sewer syndrome, the patient is also internally also female, and 5-alpha reductase male, because that 5-alpha reductase will leads to like deficiency of a testosterone normal, but 5-alpha reductase leads to deficiency of DHT. That's why female external. Puberty, masculinization. In CAIS there is no menses. Kalman syndrome. Kalman syndrome is generally a KEL1 gene mutation. KEL1 gene mutation will lead to impaired migration of GnRH neurons to hypothalamus. So in these patients, anosmia is common. There is loss of sense of smell, characterized by hypogonadotropic hypogonadism caused by deficiency in the GnRH, leading to decreased LH and FSH both. Primarily affect the males, mostly 5:1 ratio, leading to delayed or absent puberty, small testes, and micropenis. Cryptorchidism also seen, but newborn females appear normal, and it is often like discovered at puberty. If it is in females, like little or no breast development, no axillary hair, primary amenorrhea will be there. But mostly as it is occurring in the males, so males, no facial or body hair, no increased muscle mass, and failure to of the voice to deepen. So this is all about the disorders. Now we'll see how we'll diagnose. So diagnostic test of the DSD. First is karyotype. Determine the chromosome sex like XX or XY. Abdominal imaging. Identifies the presence of testis or uterus. 17 hydroxyprogesterone elevated in 21 hydroxylase deficiency. Testosterone and DHT, and based on the LH. So testosterone DHT both elevated in CAIS with reduced DHT in 5 alpha reductase deficiency. In the LH, by the LH, like you can compare these patients. Like in gonadal failure, you will see testosterone is decreased, but LH will be high because no testosterone, no negative feedback, testosterone tumor, testosterone will be high, so LH will be low. Exogenous testosterone, if a female is taking, so high level of testosterone and LH will be low. Pituitary failure, so LH will be low obviously, and so low this testosterone will be low and low LH also. CAIS, there will be increased level of testosterone, but LH is also increased. So this is very important here. In the CAIS only you will see this increased testosterone along with increased LH, because the pituitary can't sense the levels of testosterone because of the defective testosterone receptors. So this is all about the development of sexual disorders of sexual development. If you want this chart, you can comment, I'll share. Thank you.